Thank you, Gary. Good morning. I've been asked to discuss this important class of agents and give a perspective on where we are today with this class and speculate a little bit about the future. I'll confine my remarks to agents that are in the clinical development programs in which it's expected that they will reach the clinic within the next 3 years. Forgive me if your favorite molecule isn't on the list. So this really whole field came about from basic discovery regarding the mechanisms that control egress of lymphocytes from the vasculature into tissue. And this is a complex series of reactions that starts with attraction of lymphocytes in the circulation, tethering to the endothelium, then activation of adhesion molecules that allow firm adhesion, and then egress through diapedesis into the tissue. And there are multiple molecules involved, and not surprisingly, there are multiple strategies that could be exploited to prevent this process from taking place. And really the principle behind it is quite simplistic in that what you're trying to do is allow prevention of recruitment of cells that really are upregulating the inflammatory process and allow natural tissue repair to take place and prevent this, which is the final common pathway. When cells become activated, enter the tissue, then the immunological processes result in tissue destruction. So quite a simple concept. This experience really began with Vedolizumab, which was a monoclonal CDR-grafted antibody against the alpha-4 integrin. And it was originally developed as a therapy for multiple sclerosis, and I can still recall seeing this paper in the New England Journal of Medicine and saying this is obviously a breakthrough concept, because what we see here in the control group is the number of new gadolinium-enhancing lesions. You see progressive development of lesions over a 6-month period, and with 2 different dose regimens of Vedolizumab, you see complete abrogation of the pathological process. This led the FDA to fast-track this molecule for development, and we became interested in Crohn's disease. And if I was on this podium in 2005, I would have told you that this is really going to be a breakthrough drug, and it was in regard to there are very few data sets that we see as good as this one for corticosteroid-free remission in Crohn's disease over 9 months with a 30% delta. And those of you who have used this drug, Tisabri, know it is a very, very effective drug. Unfortunately, it had a very important problem developed with its use. And we've come to understand the biology of PML, the John Cunningham virus, and in terms of actually being able to use the drug right now with the advent of serology, we can actually still utilize this drug in patients who aren't harboring the JC virus. But suffice it to say that this complication really did, almost a mortal blow to the use of the drug, and had a chilling effect on the whole concept of interfering with leukocyte trafficking. We persisted, and today in the clinic we have multiple opportunities. And this is a very complex diagram, and it's showing all of the potential pathways that we could exploit here. Suffice it to say that the integrins have been the most successful approach, and I'm going to focus on those particular molecules, but there are many other potential pathways which can be utilized and have been evaluated in the clinic. So to briefly go through some of the biology here, you can see the leukocyte has receptors, integrins on its surface, and they integrate with other molecules. And the specificity of these reactions is tissue dependent. VCAM alpha-4 beta-1 interactions are present in every vascular bed in the body. So that Vedolizumab, when it interfered with that trafficking reaction, resulted in lymphocytosis. We had to actually be blinded in the clinical trials to the peripheral blood lymphocyte counts because it had a dramatic effect in raising the lymphocyte counts because of its lack of specificity. On the other hand, if more selective approach, binding alpha-4 beta-7, which is expressed, it interacts with the ligand MadCam, which is specifically expressed in the gut and the gut appendices, such as the liver, pancreas, that would really be a more selective effect because only 3% of circulating T cells express alpha-4 beta-7. There is another ligand, alphaE beta-7. Its ligand is alphaE cadherin, and that is expressed in epithelial cells. So when the pathologists show you the nice pictures of intraepithelial lymphocytes being trapped in celiac disease or microscopic colitis, that's this reaction, E-KIT here, and with regard to the interaction with alpha-E beta-7. So various monoclonals have been developed, specifically beyond that broad-spectrum approach. So alpha-4 beta-7, MadCam interaction, if you block beta-7, as Etrolizumab does, you block that interaction. And many of you will be familiar with Vedolizumab blocking alpha-4 beta-7, the shared epitope between the two dimers. Etrolizumab also blocks alpha-E beta-7 because it is directed towards beta-7. And then finally, you can have antibodies directed against MadCam itself. So this was the primary result from the induction component of GEMINI 1, which was a multi-center trial evaluating Vedolizumab, an alpha-4 beta-7 antibody in active ulcerative colitis. And in this population of patients, 40% who had failed TNF blockers, you can see a fairly dramatic result in clinical response, remission, mucosal healing with 2 doses of the antibody with evaluation at week 6, highly statistically significant results. And that was also present irrespective of whether patients had failed a TNF blocker or whether, in fact, they were naive to these agents. So this was really our first out-of-class drug, viable out-of-class drug in ulcerative colitis therapy for patients who had failed a TNF blocker. The most recent molecule to come to the clinic is Etrolizumab, and I'm showing phase 2 results here with Etrolizumab for induction therapy. These are data at week 10 in a patient population, mixed patient population, much like the Vedolizumab studies, with results showing clinical remission. And you can see that at week 10, 20.5% of a medium dose of Etrolizumab patients were in remission as opposed to no placebo patients. I'd just like to point out that we really have overcome the placebo response in ulcerative colitis trial in the modern era. And this has been by incorporating an endoscopic endpoint into our clinical outcomes and also using central reading of endoscopy by experts to overcome placebo effects. Sight reading tends to raise the placebo response rate. I'd like now turn your attention to the results from this trial conducted by Severine Vermeer in regard to subgroups of TNF-exposed patients versus naive, and you can see that the benefit clearly here was in the patients who are naive. This trial was a phase 2 study. It was relatively small, and it's not clear in my mind whether, in fact, this is just a result of small sample size or whether there is, in fact, a true biological effect. The other thing that was interesting was that the high dose of Etrolizumab, the 300 milligrams every 4 weeks, appeared to have less clinical efficacy. And I'll come back to that theme in just a minute. So this is another approach, beta-7 as opposed to alpha-4 beta-7 blockade with a monoclonal antibody. Now, Etrolizumab, really this was a striking subgroup analysis from this study. And this is, I believe, a very important concept because this is the first inroad into personalized medicine in ulcerative colitis. So this is showing an enhanced clinical effect in patients who had high expression of alpha-E in their tissues on the biopsies. So this conceivably could take us to where the oncologists are now, where we're actually tailoring drug therapy based on a biomarker in tissue. So this is a really important result. And if this is confirmed in the phase 3 program, this may lead us in a new direction, which may be applicable to other therapeutic approaches in ulcerative colitis. So tune in a couple years with this one. Now, so we've talked about anti-alpha-4, anti-alpha-4 beta-7, anti-beta-7. Well, why not just cut out the middleman and directly blockade MadCam? And these are the results of a study that were presented at the ECHO meeting last year, again by Severine Vermeer. And here we see a very interesting result in a phase 2 program in patients with ulcerative colitis. This is the primary endpoint, which is clinical remission at week 12, and a very clear benefit for the intermediate dose of 22.5 milligrams of anti-MadCam. This is a Pfizer compound. But what's really striking is if you look at the highest dose, 225 milligrams, which is a 10-fold increase in dose, you see actually a diminished clinical effect or a biphasic dose response curve. Well, the only time we've seen this before was in the early days of infliximab. And at that point, with looking back at the Targan study, we had convinced ourselves that there was a biphasic dose response curve with infliximab. Now, in the fullness of time, that turned out to be a problem really with small sample size and actually an alpha error, and concluding that there was a atypical dose response curve. I don't think we can say that for this, in fact, because I don't have the ends on the slides, but this is about 75 per group. It's a relatively large phase 3 dose finding study. So one of the interesting concepts here may be that why could there be downregulation of response with higher doses with this molecule? And I think that's going to keep our basic science colleagues busy for a little while in the future. So we've got proof of concept there, and then if we look at secondary endpoint, naive versus experienced, it looks like with this molecule there's efficacy in both populations that were evaluated. And just to summarize, for induction and Cochrane reviews, you can see the point estimates for all three compounds, and they line up pretty well, showing efficacy for this concept of blocking lymphocyte trafficking in ulcerative colitis. I'd like to move on now, and this is just the endoscopic remission data showing the same story. I'd like to move on now to maintenance therapy, and we only have data with regard to vedolizumab, and here are the results from the second part of GEMINI, the maintenance, in which patients who responded were re-randomized, and really a striking result with efficacy for both dose regimens, the Q4 8-weekly and the Q8 weekly dose regimen against placebo at 52 weeks. I draw your attention to the corticosteroid-free remission data for both doses. You can see that this is a really quite important clinical result in a difficult patient population. This harkens back to the days where we looked, the first slide I showed you with Tisabri in patients with Crohn's disease, striking corticosteroid-free remission rates, and that was echoed in this study in ulcerative colitis. And just point estimate on the Cochrane pitogram. Turning to Crohn's disease, somewhat different story. This is the GEMINI 2 study, very large clinical trial looking at patients who had failed, approximately 50% of the patients had failed a TNF blocker in the past, and the rest were naive. And you can see the trial met its primary endpoint with regard to clinical remission. This was a co-primary endpoint. Interestingly, a 100-point decrease in CDI scores was not met. The trial was a positive trial because it was pre-specified that p.025 would met that criteria, and you can see the p-value for remission. Early endpoint, 6 weeks, and perhaps this is too early an endpoint for this agent in Crohn's disease. And in support of that concept, here you see the data with regard to the GEMINI 3 study conducted by Bruce Sands. And here we have a 10-week endpoint, and we see a benefit in both populations, naive versus patients who had been previously exposed to a TNF blocker, on the endpoint of a 100-point drop. And I'm not showing the remission data, but that was also positive. So this appears to be an agent which takes a little bit longer to work for induction. Anti-MadCam has been evaluated in Crohn's disease, this report from ECHO recently, and you can see there does not appear to be a benefit in this trial from the primary analysis with very high placebo rates, interestingly enough, although the patients were pre-qualified. However, if we look at patients who had high CRPs in a post hoc analysis, perhaps there's a benefit for this agent. There are no data with regard to the anti-beta 7 in Crohn's disease induction currently. Cochrane review here for induction, and you can see benefit for both agents. I'd like now to turn to the maintenance data for vedolizumab. There are no data for the other agents, and much like the ulcerative colitis story, clear-cut efficacy summarized in this Cochrane review. So a very good maintenance drug with steroid-sparing effect in Crohn's disease. The real promise of these agents, however, I've shown you efficacy data in both populations, but really it's the safety story. Because of gut selectivity with regard to the MadCam expression, you should not affect systemic immunity, and that's been pretty much confirmed on a variety of studies with vedolizumab and the other agents in the short term. We need longer term studies, but it does not appear that there is an increased risk of serious infection, which is in fact the Achilles heel of the TNF blockers. I'd like to come back to the issue of PML. We can actually look at the risk of PML and through a technique called Poisson regression modeling, actually calculate the probability of seeing PML based on our experience with vedolizumab to date. And at this point, this was the original FDA approval model, and you can see that we would have expected to see approximately 8 cases of PML at that time with 95% certitude, and we have not observed any cases of PML. So I think this issue, we're pretty sure that this is not going to be a problem with this agent in distinction to Sabri. Moving on, so monoclonal antibodies against adhesion molecules are a new therapeutic area that have been promising. There is a new approach that is coming to the clinic, and that is S1P1 receptor modulation. And if you think about this, well, if lymphocytes have very specific mechanisms for getting into the tissue, there must be very specific mechanisms for getting them out of tissue. And what in fact happens is that they follow a gradient of phospholipids out of the lymphatics, and the lymphatic gradient increases as you exit the lymph node. T cells have a receptor on them that actually follows that gradient, recognizes the phospholipid moieties, and what happens is as they bump into the lipids on the endothelium, they keep moving in that direction. So this class of drugs actually internalize the receptor and actually antagonizes the trafficking out of the lymph node. So this, the first molecule that came on into the clinical arena was Fingolomod. It's a breakthrough drug, oral agent for the treatment of multiple sclerosis. And this is one of the pivotal trials showing efficacy, greater efficacy in MS against the standard of care beta interferon. This drug was troubled by a number of side effects, off-target side effects, including cardiac disturbances. There are 5 isotypes of S1P1, and in fact, there are development variety of drugs, including this one, Ozanamod, which was evaluated in ulcerative colitis. So Ozanamod is the first in class of this drug for the treatment of IBD. I'm showing the results of a phase 2 study that was presented by Bill Sanborn at DDW, 2 different doses of Ozanamod against placebo in an induction trial. This shows the effect, as you would expect. If you're blocking trafficking out of the lymph nodes, you'd expect a decrease of lymphocytes or lymphopenia, which is dose dependent, and that's what was observed in this study. Here are the primary endpoint of the trial, and we see significant differences for the highest dose, 1 milligram against placebo. Note again the very low placebo rate in modern trials, and similar results for endoscopic improvement at 0.1 on the Mayo score and clinical response at week 8. So it looks like dose proportionality here, indicating that this is an effective therapy. Recently, the results out to 32 weeks have been described in this study. Patients continued on therapy if they were responders at week 8, and you can see an increase in remission rates extending out to that time point, and a similar pattern for clinical response and mucosal healing. With regard to side effects, this was a short-term study, but having said that, there was not seemed to be especially a problem with infection or other issues in this study. We did observe 1 case of sinus bradycardia. This was a minor side effect, and really it looked like the previous problems with Fingolomod did not appear to be present in this initial study with the agent. So I'm going to conclude now by summarizing to say that monoclonal antibodies to integrins are really an effective new class of drugs. Vedolizumab is in the clinic. Etrolizumab and Anti-MadCam are on the way. The safety profile of these agents is excellent. We really need long-term data, but the initial promise seems to be being fulfilled. I've introduced you to S1P1 agonists. So these are oral agents that have the advantage of the convenience of oral dosing and lack of immunogenicity, and they appear to be effective in both ulcerative colitis and multiple sclerosis. So Ozanamod is the first of this class, and it is now in a phase 3 development program. And I'll close at this point. Thank you.